Hi, everyone. Welcome to our multimodality imaging lecture series here at MonteHeart. It's a great honor to introduce today Dr. Shiraz Maskatia that will be joining us from the West Coast, actually, from Stanford. He's the Associate Echo Director at Stanford. He's a multimodality imager, and he has acquired a lot of knowledge, and he has become an expert in the imaging of the pulmonary valve, a valve that is usually forgotten and has been highly recommended by the leader of the structural interventions, Dr. Rahul Sharma at Stanford. So it's a great honor to have you here today, Shiraz, and we're very excited for your talk.
Thank you so much, Dr. Slipzuk, Leonardo. It's a fantastic opportunity to present. You know, when I first got the invitation, I was just floored at the opportunity, and so I really wanted to thank you and the organizers. And I wanted to just give you a brief background to who I am. I'm a pediatric cardiologist. So again, thanks for allowing a pediatric cardiologist into your midst. And also an imager. So my clinical roles are primarily in echo and MRI, as well as fetal echocardiography. And I do work with a lot of the structural engineers, the structural cardiac interventionalists who perform these interventions. And so with that introduction, I have no disclosures. I will be, no financial relationships to disclose. I will be discussing multiple approved and non-approved devices. The use of non-FDA approved contrast agents for pediatric cardiac imaging will also be discussed, as you can see below. So we'll talk about the criteria for pulmonary valve replacement. We'll talk about the outcomes for surgical and transcatheter pulmonary valve replacement. We'll talk about various options for pulmonary valve replacement. And we'll talk about our imaging test of choice, CT versus MRI. And finally, we'll end with a case discussion. And hopefully this will keep your interest for the next 45 minutes or so. So first off, the goals of pre-transcatheter pulmonary valve cross-sectional imaging. And I've divided these into two distinct categories. Those goals before deciding a transcatheter or a surgical valve, and after deciding on a transcatheter valve. So first off, before deciding between a transcatheter and pulmonary valve, we want to confirm that the imaging-based clinical criteria for a pulmonary valve replacement are met. And we'll review these in depth, but essentially we're talking about RV size and systolic function, LV systolic function, and pulmonary regurgitant fraction. These are primarily cardiac MRI based. We'll then discuss and understand we want to understand prior interventions in the current anatomy. This is hugely important. We want to know, is it a native RVOT? Or is it an RV to PA conduit or a prosthetic pulmonary valve? Has there been a prior transannular patch, as is the setting commonly in tetralogy of Fallot? What is the pulmonary valve leaflet anatomy? And what are other surgical lesions? How much tricuspid regurgitation is there? Is there an RVOT aneurysm? Is there branched pulmonary artery hypoplasia? And hugely important is the coronary artery anatomy. Is it possible that there's a coronary artery crossing in front of the RV outflow tract that may limit our ability to put in a transcatheter valve? Once we've decided on a transcatheter valve, we need to obtain a high quality anatomic map of the RVOT, the pulmonary valve annulus, the MPA, and the branch pulmonary arteries. We want to know the proximal diameter, the RVOT length, the MPA diameter, and the narrowest dimension along this course. And then finally, we want to help our interventionalists understand the various options for a transcatheter pulmonary valve. And inherent in this is the interventionalist familiarity with the different options. So before moving on to the next phase of the talk, I wanted to review briefly the physiologic mechanisms in chronic pulmonary regurgitation. The poster child for this is tetralogy of Fallot. Tetralogy of Fallot is often repaired in infancy, and that infancy repair will lead to chronic pulmonary regurgitation. This schematic, obtained from an article written by Tal Giva in 2011, still holds true today and is one that I frequently refer to. In the standard tetralogy of Fallot patient, there's a number of mechanisms at play here which may ultimately lead to RV dysfunction and death. Inherent in this is pulmonary regurgitation, leading to chronic RV volume overload and RV dilation. That RV dilation will then lead to a decreased mass to volume ratio, increased RV wall stress, and RV dysfunction. But how much RV enlargement is too much? Overall, RV end diastolic volume, RV end systolic volume, and RVEF do change across time, but that change is relatively slow. There is a subgroup of 15 to 26% of subjects who have fairly rapid changes in RV size and function. And it's that subgroup that we are going to want to watch more closely. As you can see in these collections of graphs from 2015, the rate of change in RV EDV tends to be fairly slow, the average being maybe around 5 cc's per meter squared per year. But there is a subgroup in which it's more rapid. Similarly, RVEF can change fairly rapidly in a small subgroup of patients. Factors associated with an increasing RV size change during adolescence and young adulthood include those with a higher baseline RV end systolic volume and lower RVEF. So basically, the worse off you start with, the faster you're going to progress. That said, RV size and function do correlate. As the RV enlarges, the RV function also deteriorates, as is shown in this bar graph. When you study factors that lead to worse outcomes in this group, probably best studied is the indicator cohort, led by the group out of Boston. This is a large collection of predominantly adult patients with repaired tetralogy of Fallot who have been studied longitudinally. In this cohort, they found that LV dysfunction, RV dysfunction, increased RV mass, and atrial arrhythmia are all independently associated with the amalgamated outcome. As you can see, as you obtain further risk factors, the risk of attaining this outcome increases. So really, this is what we're trying to avoid. A big, boggy, dysfunctional, hypertrophied right ventricle, which is pressure loaded and volume loaded. This RV has gone way too far. There's significant tricuspid regurgitation, as you can see in the top left panel. There's a dysynchronous and dyskinetic RV outflow tract, as you can see in the top right panel. And there's severe free pulmonary regurgitation, as you can see in the bottom panel. But how do we avoid that? Well, inherent in this process, there's a few steps, but the major step that we can arrest is the chronic pulmonary regurgitation. And that's by replacing the pulmonary valve. But when do we replace the pulmonary valve? This has been the subject of a lot of discussion and study over the years. In 2005, Judith Tarian and colleagues published a seminal work where they looked at patients with varying RV volumes and looked at their remodeling after pulmonary valve replacement. These are all surgical valves. And if you arbitrarily define 110 as normal for RV end diastolic volume, which is indexed, you can see that anyone with an RV end diastolic volume above approximately 170 failed to remodel to normal. Almost all of them remodeled, but didn't remodel to a normal volume. Similarly, anyone with an RV end systolic volume above approximately 80 failed to remodel to a normal end systolic volume. So based on these data, people tended to use those numbers, 170 and 80. However, over the years, there's been a plethora of articles and a lot of study on exactly this topic. One of the most interesting papers I've seen on this topic comes out of CHOP. And what they did is they looked at 13 patients with both CMR and catheterization data. They used computational flow dynamics to develop models to calculate power loss. And they found that mean 20% power loss was due to specifically to pulmonary regurgitation. And if you look at varying RV end diastolic and end systolic volumes within this group, there was an inflection point at about 139 cc's per meter squared and about 75 cc's per meter squared, at which output power decreased substantially. So these are calculated values based on computational models, but led to considerable discussion about whether the volumes that were previously proposed are too large. So putting together a lot of data on this, these are criteria that folks have come up with. And I will say these were initially published approximately almost 10 years ago in Circulation and are still being revised. And we'll discuss the reasons why. But those criteria are listed above. And one thing I'll say about these criteria is I'm oftentimes asked as a pediatric cardiac imager, what number do you use? And people oftentimes tend to focus on the RV end diastolic volume index as a particular number to rely upon. And I try to discourage that. I try to have them use all of these criteria as a whole. So we really want to look at a lot of exercise data, symptomatic data, clinical data, and then in addition to that, a lot of MR characteristics, including RV size, end diastolic, RV end systolic size, and functional measures of both RV and LV. However, these criteria are far from perfect. If you compare patients who have or have not had a pulmonary valve replacement in the setting of chronic pulmonary regurgitation, certainly pulmonary valve replacement reduces RV end diastolic and end systolic volumes. However, most data show that it doesn't actually change ejection fraction. If you look at this paper published by Dave Harold out of Boston Circulation in 2009, they found that the probability of freedom from VT was no different in patients with and without pulmonary valve replacement. And the probability of survival was actually almost slightly higher in those in control patients relative to those who had a pulmonary valve replacement, although that did not meet statistical significance. And granted, these are relatively small numbers, but there was not a strong trend towards improvement in freedom from VT or survival in those with a pulmonary valve replacement. In this study out of the Canadian Journal of Cardiology in 2019 demonstrated that in some adult studies, there was an improved NYHA class in pulmonary valve replacement. So I'm not trying to argue that pulmonary valve replacement is not a good therapy and something that should be performed in people who meet these criteria, but we have to be a little bit careful about applying strict criteria to this group. Perhaps most sobering was this study published in 2018, again, out of the Boston and Netherlands groups. And what they found is if they looked at all amalgamated studies that had been published in this space, and they separated them out into those who achieved a primary outcome, which is death, aborted and started cardiac death and VT, and a secondary outcome, which is heart failure and arrhythmia. They then separated patients out into those who met proactive criteria, so met strict criteria for pulmonary valve replacement, and those who had a pulmonary valve replaced despite not meeting that strict criteria. And what they found was, again, in terms of the primary outcome, there was no real difference in patients with or without pulmonary valve replacement. And in the secondary outcome measures, the lack of a pulmonary valve replacement or not undergoing a pulmonary valve replacement was actually favored. So in essence, we need to be particularly careful about patient selection when undergoing pulmonary valve replacement. I'll now want to talk about alternatives to surgical pulmonary valve replacement. And of course, most of this talk will be about transcatheter pulmonary valves. However, I did want to bring up one other option, which is a surgical pulmonary valve repair. This is not something that's generally discussed very much in the congenital world. However, our surgeons approximately 2 decades ago began looking at these pulmonary valves in the OR and thinking, well, is there an option to repair this valve and save the patient from a lifetime of needing future pulmonary valve replacements? And when we looked at this group, we found that patients who had a pulmonary valve repair were less likely to have severe, moderate or severe pulmonary regurgitation and follow-up. Now, of course, you have to have significant leaflet tissue to undergo a pulmonary valve repair. So we briefly looked at various indices of pulmonary valve leaflet size obtained on both MR and echo, and came up with various indices to guide us in terms of whether or not a pulmonary valve repair would be possible. This was particularly impactful because those who met criteria as potentially being candidates for a pulmonary valve repair were then not referred for a transcatheter valve. And moving on to transcatheter pulmonary valves. Most people are familiar that the first percutaneous placed pulmonary valve was by Philippe Bonhoeffer and published in Lancet in 2000. And he created a pericardial, bovine pericardial valve sewn into a bare metal stent and implanted it in a 12-year-old with chronic pulmonary regurgitation. Since that time, there's been a dramatic increase in experience in transcatheter pulmonary valves. This is one study published in 2017 out of Jaha, and is a meta-analysis and review of transcatheter pulmonary valves. And as you can see, the outcomes are quite good. Procedural success is quite high, complications are low, and I won't go through all of these data, but the outcomes are particularly promising and quite good in transcatheter pulmonary valve. Specifically looking at potential complications in transcatheter pulmonary valve, again, rates are particularly low with stent fracture or reintervention, about 4 per 100 patient years. And as a group, endocarditis is particularly low at 1 event per 100 patient years. That said, we'll talk more about that in a minute. This study published in 2017 looked at changes after transcatheter pulmonary valve and found, not surprisingly, that RV end diastolic volumes did decrease fairly effectively. But interestingly, RVEF did not improve after placement of a transcatheter valve. And really there was a trend towards decreasing RVEF. Here it reached statistical significance, but the effect size was fairly small. So just like surgical pulmonary valves, although there is remodeling of the RV, there wasn't a demonstrated improvement in RV ejection fraction. Now, this study also separated patients out based on how long they had been sitting with pulmonary regurgitation. They separated patients out into those who had less than 7 years of chronic regurgitation and more than 7 years of chronic regurgitation. And what they found, interestingly, is that patients who were sitting for less than 7 years with chronic regurgitation actually had a more significant improvement in RV size compared to those who were greater than 7 years. So this further push the idea that potentially we should be intervening sooner if the option is a transcatheter valve as opposed to a surgical. There's been a few studies comparing transcatheter pulmonary valves to surgical valves. These studies are inherently flawed as they are largely retrospective with all of the inherent biases which accompany those. That having been said, there is some important data to look at. This meta-analysis published in 2020 in the Annals of Thoracic Surgery is probably the best source of data that we have. And compared to surgical pulmonary valve replacement, transcatheter pulmonary valves appear to have shorter hospitalization, fewer complications, and lower rates of reintervention. They appear to have equivalent mortality as well. And so that's promising. Now, that said, there is a concern for a higher rate of endocarditis. This forest plot here shows that fairly consistent finding across studies, especially when pooled, that there's a concern for increased risk of endocarditis in transcatheter pulmonary valves. They also tend to result in lower initial charges, but in another meta-analysis published in the American Journal of Cardiology in 2018, the 5-year charges were actually higher. And they supposed that that was due to a higher rate of reintervention. So the rate of reintervention in surgical versus transcatheter valves is not a question which has been answered. And I would submit that the endocarditis question has not also been answered because I think these meta-analysis, when you pool all of the data, it gets a little bit murky. But there is that concern. So once we've decided to implant the pulmonary valve, now what? Well, briefly, I'd like to review the existing transcatheter pulmonary valves. These are frequently separated out into balloon expandable valves and self-expanding valves. Balloon expandable valves have been around longer. These are primarily those that we would place in hardware. So in patients who have an RVDPA conduit, in patients who have a prosthetic pulmonary valve. Now, that being said, we have many, many patients with chronic pulmonary regurgitation who do not have hardware. And so that led to the frequent off-label use with pre-stenting or primarily placing those balloon expandable valves in native outflow tracts. On the other side of the coin are self-expanding valves. Self-expanding valves are specifically designed for placement in native outflow tracts. And we will review these. Balloon expandable valves include the Medtronic Melody valve and the Edwards Sapien valves. Those have been approved for implantation in the pulmonary position, again, in the context of hardware. The only current FDA-approved valve in the self-expanding category is Medtronic Harmony valve. We'll go through all of these valves in depth shortly. So, balloon expandable valves. The Medtronic Melody valve is a bovine jugular vein sutured into a platinum iridium stent. The first human implant was in 2000, and it was approved for use in Europe and Canada in 2006. Like most things in the US, we were a little bit behind, and US post-market approval was obtained in 2015. It's approved for valve-in-valve placement, which is crucial. You know, once these valves, as a pediatric cardiologist, one of the things I'm often asked is, when this valve fails, what's the next step? And so a valve-in-valve option is a great opportunity. There are many different sizes. The 1610 can be expanded to 16, 18, or 20 millimeters. The 1810 to 1820 or 22 millimeters. That said, these valves are frequently used outside this range and frequently up to 24 millimeters. There's substantial data which has been shown that expansions up to 24 millimeters are effective. There is a lot of literature on outcomes after Melody implants. This paper published in Circ Cardiovascular Interventions demonstrates that at 10 years out of implantation, those greater than 21 years of age are about 64% free from transcatheter valve dysfunction. And there is a difference between those who had implantation at less than 21 or greater than 21 years. This completing risk plot on the right-hand side shows, again, at about 10 years out, 55% are free from death or reintervention. This paper out of Circ Interventions, again, in 2019, looked at outcomes after Melody valve placement. And what they found, interestingly, is that endocarditis and transcatheter valve dysfunction was more common when placed in children as opposed to adults. And that those greater than or equal to 13 years old at time of implant were 90% free from explant at 5 years of age. So as a pediatric cardiologist, these data are quite helpful. It's a little bit controversial, but what I would say as a clinician is that I'm a little bit more wary of placing these valves in children less than 12 years of age, as opposed to those greater than or equal to 13 years of age. Next, the Edwards Sapien valve. The Edwards Sapien XT is a second generation valve. The original Sapien valve was originally developed for aortic valve regurgitation. It's a bovine pericardial valve on a cobalt chromium stent, and it's partially covered by a PET fabric skirt. They received FDA approval in 2016 for pulmonary implantation. It's shorter and wider than the Melody valve with a more robust stent frame. And as such, will typically not need any sort of stent reinforcing, particularly in the area of narrowing. You can see the various sizes listed here. The Sapien 3 is also FDA approved and is the same as the next generation after the XT. It's the same stent material and structural characteristics, although it also has a cuff at the base of the stent to protect against paravalvular leaking. It is effective for treatments of pulmonary stenosis and regurgitation, and has a procedural adverse event of about 10%. Now, in reviewing this recent paper out of JACC, that 10% procedural adverse event rate was fairly broad. The types of events included those that were relatively minor. The landing zone diameter can range anywhere from 16.5 to 29 millimeters, although speaking with interventionalists that I work with, they tend to be more comfortable with this valve at larger dimensions. So in comparing the Melody and the Sapien valve, the Melody valve is particularly helpful in relatively smaller outflow tract sizes, has a softer frame, and there's some concern for endocarditis at smaller sizes. The Sapien XT or 3 is what tends to be used at a larger size, has a shorter, dense frame. So if there's a particular area of narrowing, especially if it's a discrete area of narrowing, that can be helpful. And in native outflow tracts, it's oftentimes used with a pre-stent. And so we'll talk about that in a second. So now, self-expanding valves. And I will say this is a very exciting area of investigation currently, and data are rapidly evolving. So first, the Medtronic Harmony valve. The Medtronic Harmony valve has a nitinol stent frame, has a fabric which lines the inside. It's a tri-leaflet porcine pericardial tissue valve, and as you can see, is flared at both ends, both the RVOT and the pulmonary artery end. They received post-market approval just last year, and long-term data, although long-term data are not available, midterm data are quite encouraging. There's two types of valves, the 22 and the 25, and we'll review their qualities in a second. I did want to bring up a very recent finding that we just noted here at Stanford. Ventricular arrhythmias are relatively or something that we noticed after transcatheter pulmonary valve replacement, specifically using the Harmony PV25, the 25 size valve. We found non-sustained VT in 40% of patients, particularly when that valve was implanted in an annular position. Now, the majority of our experience is that this VT is short-lived, it's not very clinically significant, but that being said, it is VT, and it's something that raises a decent level of concern, particularly amongst those caring for these patients in the immediate post-cath setting. We thought that perhaps that could be due to mechanical irritation of the surrounding structures and potentially including the RV myocardium, and that it was associated with implantation at the annulus as opposed to above the annulus. I do want to say that I don't want to overstate the importance of this. Many of these finding has not caused us to halt implantation, has not caused us to not implant these valves if people have a history of PVCs. It just causes us to be a little bit more mindful of VT, if non-sustained VT, if it's placed in the annular position. Now moving on to the Edwards Altera adaptive pre-stent. This is a docking station which consists of a scaffolding that is made of a nitinol frame and is covered with fabric on the inside and on portion of the outside. This is used prior to placing a Sapien 3 valve. So in the past, the Sapien 3 valve was frequently used in a pre-stent in the native RVOT, but now the adaptive Altera pre-stent is being studied as a option for native RVOTs. There's limited follow-up data, and it's now undergoing post-market approval trials. So this is an exciting and potential solution. A few valves have been developed outside of the US, and for, I think any balanced talk should include these valves. The Venus P valve was developed in Shanghai as a nitinol frame and is covered with porcine pericardial tissue, which houses porcine pericardial valve. It's again flared at both inflow and outflow portions, and there are several multi-center studies that demonstrate its utility. This is just one citation. These valves are not available in the US. The Taiwan Postal valve is again another international valve developed in South Korea. It is a more recent development, although 6-month follow-up data are quite promising. The Zenith PT Valve was another valve developed in Beijing. Again, has a self-expanding nitinol frame covered internally by porcine pericardium, and is fairly limited in terms of the reports of its efficacy out there. But outside of the US, particularly in China and other countries, these valves are being used frequently with a great deal of success. So now that you've decided to implant the transcutaneous pulmonary valve, the next step is developing a high quality anatomical map. And one of the questions that comes up is, do you recommend CT or MR? Well, as most people in the audience will know, there are some technical differences between CT and MR angiography. A CT angiogram is generally we generally do require that to be ECG gated with the spatial resolution of 0.7 to 1 millimeters. However, with the CT angiogram, you're generally not going to be receiving functional imaging. There is a significant radiation dose, and it uses an iodine-based contrast agent with potential nephrotoxic effects. MR angiography, on the other hand, in general, tends not to be ECG gated. We will talk about ECG gated MR angiography a little bit later in the talk, but generally is not ECG gated. The spatial resolution generally is worse than CT. However, MR angiography can be paired, and oftentimes is paired, with functional MR imaging. So if a patient is referred for functional imaging, we'll oftentimes pair that with an MR angiogram in case they're a candidate for transcatheter intervention. There is no radiation dose, and the contrast agent is generally not nephrotoxic. So this is a case of a patient who's 20 years old with tetralogy of Fallot and has undergone a transannular patch as an infant, now with chronic pulmonary regurgitation. As you can see by the short axis and 4-chamber views, the RV is markedly dilated with preserved systolic function. And so based on clinical and MR criteria, this patient met criteria for a pulmonary valve replacement. They had a regurgitant fraction of 40%, so at least moderate pulmonary regurgitation, and there was minimal leaflet tissue. And I bring up the fact that there was minimal leaflet tissue because at our center, if there's significant leaflet tissue, this is one that we might have considered for a surgical pulmonary valve repair as opposed to a replacement. However, with minimal leaflet tissue, this patient was referred for a transcatheter valve. Below are is the result of MR angiogram. Now this is an ECG gated MR angiogram. Generally at most centers, MR angiography tends to not be ECG gated. We thankfully at our center do have access to an ECG gated angiogram. And as you can see, this angiogram produces fairly high quality data, which can be used for procedural planning. For comparison's sake, I will show the same patient underwent a CT angiogram. And as you can see, there is higher spatial resolution with CT angiography. And you are able to generate fantastic 3D models from each. So then this patient underwent consideration for a transcatheter harmony valve. This patient is had a native RVOT, and so the only FDA approved valve for him was a harmony valve. That being said, as we discussed above, there are many options out there that are not FDA approved. But for the harmony valve, we did obtain the pre-implant CT angiogram and made some measurements that are shown here. The first measurement you're going to want to make is the length of the outflow tract. And so to determine that, we measure in orthogonal planes the outflow tract from the RVOT to the PA bifurcation. And that measurement was 57 millimeters. And as you can see, the 22 valve is actually slightly longer than the newer generation 25 valve. And that's because after some feedback from implanters and cardiologists, Medtronic found that there was a lot of interest in a shorter valve. And so that's why the newer generation larger valve, the 25, is slightly short. We then measure the RVOT proximally. We measure the RVOT immediately where it's surrounded on all sides of myocardium. And as you can see, orthogonal planes, that measurement was 23 by 35 millimeters. That same region for the Harmony 22, the suggested anatomical size of the outflow tract is 23 to 39. And for the 25 valve, the suggested anatomical size is 32 to 48 millimeters in diameter. And so this one would generally fit both, but moving on to the next level, we then measure the RVOT in the mid MPA region, and we measured about 25 by 33 millimeters, and greater than 22 for the 22 valve or greater than 25 for the 25 valve is what they recommend. So again, would it fit both? And then finally, prior to the bifurcation, we measured 26 by 35 millimeters. And again, this is where you keep marching up through the MPA. until the MPA is no longer surrounded on all sides. And there we measured 35 by 26, which is probably a better, so we found that they're probably a better candidate for the 25 valve. Now, that being said, for the Harmony valve, the current clinical practice is for the CT to then get sent to Medtronic. And Medtronic derives a perimeter derived dimensions at various points along the MPA and RVOT. And based on that perimeter map, we'll create a best fit model. And so these are perimeter derived maps at various points and at various points throughout the cardiac cycle, both in systole and diastole. And then these are the two perimeter derived maps. And as you can see, they create perimeter derived maps for both for the anatomy and compare them to both the 22 and the 25 valve. And in this case, the 25 valve best fit the anatomy relative to the 22. And so that's why that is the valve that was implanted. In the last few minutes, I just want to talk briefly about the a few tricks that we have at Stanford. We employ a lot of 4D flow imaging. Most of the uses you'll hear about 4D flow imaging are generally for assessment of flow. It's a 4D phase contrast technique, which will replace a lot of 2D phase contrast acquisitions. However, here at Stanford, we oftentimes will use pheromoxetol, which is a blood pool contrast agent, to enhance these images. And we've made quite a few advancements in the ability to accelerate these sequences and achieve even smaller resolution than a standard MR angiogram. So frequently at our center, it is routine for us to use ferroheme and obtain an MR, a 4D flow acquisition such as this with 30 cardiac phases and a sub-millimeter resolution. This takes about 15 minutes of acquisition time and is entirely free breathing. And so this is a patient with tetralogy of flow who had who has chronic pulmonary regurgitation, who was referred for MR. Not only are we able to, one of the benefits of the 4D flow technique is we're then able to image the RVOT in various planes, including the standard RV3 plane and the standard RV outflow tract plane. We're also able to create short axis planes and obtain all of the end diastolic and end systolic volume data for functional imaging. We're also able to use these 4D flow sequences to derive all of the measurements that we need for a placement of a transcatheter valve. And then finally, the actual flow data is also used to determine the pulmonary regurgitation fraction, the differential pulmonary blood flow, and all of those quantitative data that are necessary. And then finally, even talking about leaflet area, we're able to visualize the leaflets, measure their area, and determine if this would be a candidate for a surgical repair versus replacement. So in summary, we've discussed that preoperative criteria for pulmonary valve replacement, although studied extensively, unfortunately is still not entirely straightforward. Criteria may be different based on a transcatheter versus a surgical pulmonary valve. It's important to ensure that there are no coincident surgical lesions or contraindications to transcatheter valve, such as the LAD crossing the RVOT. And it's very important to obtain high quality, oftentimes ECG gated preoperative imaging. Generally, that's a CT angiogram at many places, although ECG gated MR angiography is now becoming more and more available. And then finally, I recommend partnering with your institution's interventionalist as both of you gain experience in these valves, particularly for self-expanding valves, as this is just a golden age in the development of these valves, and it's very exciting. And so with that, I'd like to thank you very much for your attention and acknowledge both my collaborators, my mentors, and the folks that helped me from a catheterization standpoint in developing this talk. This is a picture of our Echo Lab on Halloween, where we won the prize for the best coordinated costumes for the movie Coco. I am a pediatric cardiologist, so I had to mention that. And with that, I'll thank you for your attention.
Thank you very much, Dr. Maskatia. That was great. Amazing pictures that you showed, and that femoxytol 4D, I think, looked amazing. And we have also Dr. Chautier, Nadine joining us. Thank you for joining us. And if you would like to start with the first question, Nadine.
Sure.
You're muted.
You're muted.
Okay, I'm sorry. Hi, everybody. It's really nice to hear this talk and to see Shiraz on Zoom. So, you know, it's interesting. You showed all this data, and I'm happy that you focused on the message, which is, you know, we don't focus when we decide to replace a valve. There's a lot of imaging data out there, but there's a lot of data that says symptoms and arrhythmias are important in the clinical decision making. Is, you know, not to use one data point. So that's great. And one of the things I wanted to ask you is, and that always comes up, is, you know, we have the indicator trial that focuses on intratracheal flow, that focuses on, like, for example, the RV mass to volume ratio, that came out to be an indicator of poor outcomes in these patients. But we do know, for example, that RV mass is very difficult to measure. There's high inter and intra-observer variability. So how do you, in your center, like, what algorithm do you use in general to decide on pulmonary valve replacement? And how do you decide when you make a decision for pulmonary valve replacement, how do you decide, are you going MR versus CT?
Yeah, thank you very much for that question, Nadine. It's great to see you as well. It's a difficult question. You know, I think one of the most common questions we get is, what number do you use? And I always sort of bristle when I hear that, because there's clearly not one number that you can use. It's really putting it all together. If a patient has chronic regurgitation, has a dilated RV, and has symptoms that have gotten worse over time, then you have your answer, right? That's the sort of easier scenario. And so in my practice, I use once the RV starts to get pretty big and I'm sort of starting to think about it, I use serial exercise testing quite a bit. I rely on parents to let me know if patients are getting symptomatic, because oftentimes in teenagers and you know, young adults, they're not going to tell you if they're symptomatic, or they may not have the best sort of insight into that. So I definitely rely on parents to tell me. But aside from that, if it's an asymptomatic person, their RV is dilated, maybe they meet one or two of the criteria, but not all of them, then it gets pretty tough. I do think that, you know, in the kid who's fully grown, older than 13, and has a large RV, is asymptomatic, and is a good transcatheter candidate, I will be a little bit quicker to pull the trigger than for a surgical valve. It's just that much harder to send a patient to surgery than to the cath lab, you know. As much as I love surgeons, work with surgeons all the time on a daily basis, it's just so much harder to put a patient through surgery than through a catheterization. After a transcatheter valve, they're out the next day, you know, and they feel great. And so I personally have a slightly lower threshold. There's some data to support that, although it's not great data, to be honest with you. It's not mountains of data, but there's a little bit of data to support that, and I think that's I think that makes sense. In terms of CT versus MR, for me, it's pretty easy. I choose MR. We have ECG gated MR angiography. We have a very high resolution 40 flow. And so, you know, we're able to get the imaging that we need from MR. That being said, for the Harmony valve specifically, right now, Medtronic asks that you send a gated CT. And so we do that. We do that, of course. One thing that we're looking at is the gated MR angiography versus CT, and whether you can use MR angiography as opposed to CT in that context. But generally, I would favor MR for all the reasons I listed, because the patient's already getting an MR to look for the functional stuff, and you know, there's no iodinated, there's no radiation and no iodinated contrast agent. Another sort of related question for me as an imager is the use of gadolinium. You know, as I'm sure you all know, and many in the group well know, there's this increasing concern about the use of chronic use of repeated doses of gadolinium and brain deposition. You know, that concern may or may not be well founded. From what I understand, there's not been any sort of correlated clinical findings in that, although you know, certainly we wouldn't want to be cavalier about it. And so many institutions across the country are now, for their standard tetralogy flow follow-up exams, are performing non-gadolinium studies, just performing you know, standard SSFP acquisitions for functional data, maybe some 2D PCs, and then at times they'll perform non-contrast angiograms, like a 3D SSFP or something like that, which I think is quite reasonable. The downside to that approach is that if then that patient meets criteria for transcatheter valve, then they have to come back for an angiogram. And so we generally have not taken that approach. We generally will give gadolinium for any follow-up TET. That said, you know, it's something we've been discussing, because although, you know, I personally think that maybe the concerns about chronic gadolinium use have been a bit overblown, I don't want to be cavalier about it. And so I'm curious to hear your guys' thoughts about that as well.
So we actually ask before tetralogy of flow scan is being done. I mean, we're a small program, and so we have the liberty of talking immediately to the referring physician and asking, is this pre-implantation? Are you concerned enough, or is this a routine follow-up? And we usually take it from there. We often image these patients every 3 to 5 years. And I like 3D SSFP if I don't have to give, if I'm not interested in the gadolinium, like we tend to get really good results with that. So we can go with that. When it is a pre-implant, we haven't started with the Harmony, but we've had a few candidates. And when we've known it's a native RVOT and possible candidate for Harmony, we usually send them for a CT scan. So our ACHD specialist would send them for a CT scan, and it's kind of has worked for us for now from that standpoint. But we also have, you know, our patients, you know, we're not a place where we're scanning them every 2 years to say this is truly a follow-up scan. Sometimes they come after 5 years, 6 years, just given our patient population. So sometimes it's as if it's a new scan all over again. So
that's great. And Shiraz, I was going to ask you, from what you presented, the case you presented, the patient didn't qualify as a severe PR, but it seemed like you thought that given the RV size, the patient would still benefit from the intervention. And so it's very interesting to me as how we're seeing that these interventions were done early, in particular in patients that already show a hemodynamic compromise. How do you think that, how do you reckon that, how you put it together, the value of the regurgitant fraction and volume in higher ventricular sizes and when to intervene?
Yeah, I love that question. I love it because it's something that that we think about a lot and has actually been studied. And when you look at patients who have undergone MR with repaired TOF, the percent regurgitant fraction does not necessarily correlate with the degree of RV dilation or the hemodynamic impact. It's a little bit counterintuitive, but there's so many factors that result in RV dilation and dysfunction, not just the degree of PR. So criteria for putting in a pulmonary valve isn't a particular number of pulmonary regurgitation fraction. I mean, they have to have some significant degree of regurgitation, at least moderate regurgitation. But once they meet that threshold of moderate regurgitation, then the criteria move on towards the hemodynamic impact. You know, they could have 35%, 40%, 50%, 60% pulmonary regurgitation, and it wouldn't really matter. What really matters is the impact of that regurgitation on the heart. You know, that figure from Talgiva's paper, I look at it all the time. It's so eloquent, and it just lays out all of the, or a lot of the influences on RV size and function. Things like whether or not they had a large RV incision, what the electrical conduction is like, if there's an RVOT aneurysm, if there's regional dysfunction, if there's fibrosis, and there's so many factors. And so just the number of regurgitation, of course, you want them to have significant regurgitation, because if they only have 10% regurgitation, replacing the valve is not going to do anything. But once they meet that threshold of moderate regurgitation, then the percent regurgitation doesn't really matter.
Yeah, we have actually seen, and I'm sure you've seen that as well, is sometimes the regurgitant fraction doesn't change, but the RV dilation is worse or the RV function is worse. And sometimes the RV dilation is the same, but the LV function is worse because of ventricular-ventricular interaction. And that's when you're really worried in those patients. And so that's why, for example, at Monte, all these patients are discussed in conference, sometimes just to review the MRI or the CT scan and to see what those numbers mean for this particular patient, not because we're discussing any intervention, only to put the pieces together with the rest of the team. So.
Yeah, that's very interesting. Do you see any thrombosis on these valves afterwards? So what is your approach with antiplatelet or anticoagulation?
Yeah, everybody's on an aspirin. You know, for transcatheter valves, in surgical valves that actually I should say that not for all transcatheter valves, but for many transcatheter valves, patients are on an aspirin. For RV to PA conduits, the practice varies from institution to institution, from practitioner to practitioner. I do keep my patients on an aspirin, but if there's any sort of hint of a side effect, or even a little bit of bleeding when they're brushing their teeth, or some easy bruising, then I'll stop it. And similar with valve prosthetic pulmonary valves, they don't routinely require anticoagulation across the board, or even antiplatelet therapy. There's no anticoagulation, but even antiplatelet therapy across the board.
Nadim, maybe we should be doing Ferumoxytol 4D. I mean, that looks so beautiful, that picture he was showing. That was with the GE?
Yeah, those are the GE. Do you guys have you told me you have access to GE and 4D, yeah. Siemens?
We mostly usually do our congenitals on a 1.5 Tesla Philips. Yeah, I don't think we have, I don't know if someone from radiology is on, or Leandro, you would know, but I don't think we have approval for Ferumoxytol yet. It would be great if we can. It's a great great imaging, great vascular pictures.
Yeah, there is some concern, and a valid concern for reactions. In younger patients, it's less common. In older patients, it's more common, particularly those who have a history of allergic reactions. And so particularly in adults, we use it more sparingly, meaning we use it less. And in those adults with previous allergic reactions to other medications, we're much less likely to use it. For example, I recently have a patient who had a gadolinium reaction and has a history of multiple reactions. And, you know, some of us thought, well, they had a reaction to gadolinium, let's try ferumoxytol. But this is a relatively older patient, and their risk of having a ferumoxytol reaction with a prior reaction to other medications is much higher. So you have to be prepared to react to those or to treat those reactions, just as though you're giving any other medication in a medical care setting. But that has caused some legitimate concern about giving ferumoxytol. We use it very frequently, and the risk of reaction is fairly low. But we've definitely seen it, and we treat it. And the kids
what are some of the reactions that you're seeing in adults versus kids? And
so the most common reaction is a rash. It's not just generally urticaria or hives. It's generally a sort of lacy red rash that may or may not be pruritic. And then interestingly, the sort of typical ferumoxytol reaction is with hypertension, not hypotension. And so they tend to get hypertensive. They tend to have a rash. Oftentimes they're pruritic. We have a whole protocol that we use to treat them, which starts with Benadryl, and that tends to treat it effectively. We have seen true anaphylactic reactions with urticaria, with anaphylaxis, but that's very rare, very rare.
And have you, how does that compare, for example, to gadolinium reactions you have seen in terms of anaphylaxis? Because we've had one case at our institution. And then also how do these two compare if you were to give your own experience with reactions? Both.
I think reactions are more common in ferumoxytol, but true anaphylactic reactions are quite rare in both. But this sort of hypertensive ferumoxytol reaction is more common. It's it's not something that I think is, for us, limits our use of it. We just need to know to treat it if it comes up.
And what I guess what lesions or indications are you using it? If you were to decide between the two, obviously, I'm assuming if you're interested in vessels and vascular structures and intracardiac, I guess.
Yeah, we generally will use ferumoxytol. We'll specifically use gadolinium, of course, if there's any concern for viability. If we want to look at fibrosis, then you have to use gadolinium. But our bias is much more towards using ferumoxytol, specifically because our 4D flows have been tweaked and studied so extensively. I've found them very helpful in any sort of regurgitant lesions. AV valve regurgitation specifically it's really, really helpful. We recently published a paper on that in JCMR. And then the last thing I'll say about it is, all of this work in terms of the development of the 4D flow sequences, the AI-based reconstruction of them, the use of ferumoxytol for enhanced SNR, all of that is based on Shiraz's work. Shiraz Vasanawala, who's the director of our radiology program, the chief of pediatric radiology. I mean, he's really been a pioneer in this world. So when I came here to Stanford from Texas, it was like, wow, there's toys here that we did not have in Texas. And that's really because of his work, and it's really cool.
Yeah, great. Thank you very much. That was an outstanding lecture, and hopefully we see you in person soon.
I'd love that.
Okay, take care. Thank you, Nadine.
Take care. Thanks a lot. Thank you so much for the opportunity.
Okay. Bye.
Bye.